Chapter 21, Caring for Head and Spinal Injuries. Define the following terms: central nervous system, cranium, paralysis, peripheral nervous system. Describe the major components of the spinal column. Describe the major components of the nervous system. Describe the major components of the cranium. Describe the relationship of mechanism of injury to the potential for spine injury. Describe the signs and symptoms of a head injury. Differentiate between an open and closed head injury. Explain the appropriate assessment and care for a patient with a head injury. Describe the signs and symptoms of a spine injury. Explain the appropriate assessment and care for a patient with a suspected spine injury. Explain the special considerations of airway management for a patient with a suspected cervical spine injury. Demonstrate the appropriate assessment and care of a patient with a head injury. Demonstrate the appropriate assessment and care of a patient with a suspected spine injury. Demonstrate the appropriate airway management for a patient with a suspected cervical spine injury. Demonstrate the appropriate technique for manual stabilization of the cervical spine. Demonstrate the appropriate sizing and application of a cervical collar. Demonstrate the proper technique for log rolling a patient. Demonstrate the proper technique for immobilization of a supine patient. Demonstrate the proper technique for immobilization of a seated patient. Value the importance of proper body substance isolation. Precautions when caring for patients with head and spine injuries. Alright, this is anatomy of the head and spine. It's going to be a review of the anatomy and physiology chapter from earlier in this class. Alright, the cranium or skull. This sits at the top of the spinal column. It's able to twist and move in many different directions. The cranial vault is the area inside the skull where the brain is located. Face bones. This includes the cheeks and part of the eye sockets. Upper part of the nose, upper and the lower jaw. Central nervous system, responsible for many bodies' involuntary function to include heartbeat, respirations, thermal or temperature regulation. The peripheral nervous system, nerves that extend from the spinal cord throughout the rest of the body. This figure 21.1 shows the bones of the skull. You can see at the top you got the cranium, the zygomatic bone and the cheekbone. You got the nasal bone right in between the nose. The maxilla is the upper jaw. The mandible is the lower jaw. Meninges is three protective layers surrounding the brain. Cerebrospinal fluid. This is a clear fluid surrounding the brain and the spinal cord. Spinal column. This begins at the base of the skull, extends down into the pelvis. It's comprised of 33 bones called vertebrae. Right, the brain is protected in by several layers of tissue called meninges. This image is kind of hard to use to explain it, but if you'll look at the bottom image, you see the square that's cut out. The pia mater is directly attached to the brain itself. Then above that, you've got the blue square, which is the arachnoid matter. It's kind of a web-like, meshy substance. Then above that, you've got the dura mater, and this is the thick connective tissue that's covering the brain, and it attempts to keep the brain from being injured itself. See if I can get some examples of that for class. All right, the segments of the spinal column. Look at your image down here. You got your cervical. This is starting at the top. It's in green. Thoracic. This is the one below that. It's in the pinkish color. Lumbar is blue, and sacral is the standard bone color. All right, is the spinal cord damaged every time a vertebrae is broken? The answer to that is no. Could a person break his neck without damaging the cord? Yes, that can happen. That's why you apply a cervical collar to prevent cord injury, even if there is a broken neck. All right, mechanisms of injury. Falls, forces that cause excessive flexion, bending, or extension of the neck or the spine. Pulling or hanging forces that cause spinal stretching. Motor vehicle crashes. Contact sports. Significant blunt trauma. Penetrating trauma. Blows by assault and battery or abuse incidents. Any trauma situation where the patient is unresponsive. All right, you respond to a gymnastics center where you find a 16-year-old female supine on a mat under a balance beam. The coach reports that she attempted an aerial dismount and struck her head on the beam. She is unresponsive. What are your concerns? How will you proceed? All right, so we got a 16-year-old female supine, which means she's laying on her back on a mat under the balance beam. The coach reports that she attempted an aerial dismount and struck her head on the beam. She is unresponsive. All right, so our concerns are some type of head injury or a spinal injury. We're going to proceed by completing our primary survey and immobilizing her on a long spine board, continuing with patient care after that. Injuries to the head and the face. Injuries to the head, commonly caused by blunt trauma. Closed injuries occur when the cranium remains intact. These include concussions and contusions. Alright, this is bruising around the eyes. It can be a sign of a closed head injury. A lot of people either call this raccoon's eyes or ecchymosis. If it's around both eyes, it's called periorbital ecchymosis. Alright, open head injuries. The cranium and overlying soft tissue are broken, exposing the brain and other tissues within the skull. It's best to assume that the head injury is open and care for it accordingly. Alright, so one thing to think about is a open or closed head injury more dangerous. They're both bad, but a closed head injury, you can have a significant increase in pressure inside the cranium, which can cause you a lot more issues. So in general, closed head injuries are a little bit more significant and dangerous than open head injuries. Alright, signs and symptoms of a head injury. You have bleeding of the scalp, deformity of the cranium, altered mental status or unresponsiveness, nausea and vomiting, convulsions. One thing to keep in mind is the scalp is highly vascular and it's going to bleed just extremely profusely even with a minor injury. Just make sure you apply direct pressure. It's going to stop most bleeding of the head. You also may see abnormal vital signs, abnormal breathing patterns, combative behavior, repetitive questionings, repetitive questions. Alright, so when you're caring for head injuries, you want to maintain a manual stabilization of the head and the neck. Complete your primary assessment. Ensure the ABCs are intact. Rescue breaths using appropriate barrier devices. Control any obvious bleeding. Keep the person still and laying flat. Administer supplemental oxygen if your local protocols allow. Have suction prepared in case a person vomits. Monitor vital signs including mental status. Injuries to the face. These can be very serious due to the potential for airway obstruction. Blood in the airway is going to be the cause of this airway obstruction. Deformities or depression of any part of the face, swelling and or discoloration around the eyes. Alright, how might you locate the airway of a patient with a significant facial trauma when the lips and nose are missing or not recognizable? One good way to do it is just to look for bubbles. If the face is so messed up that you can't even recognize the nose or mouth, when they're breathing in and out, you're going to see some bubbles going through the blood, and that's going to be the location of the nose or the mouth generally. Alright, swelling or discoloration of any part of the face, poor function or inability to move the jaw, teeth that may be loose or knocked out, broken dentures. Alright, so you want to be alert to possible airway compromise with injuries to the jaw and mouth. Alright, care for injuries to the face. Make certain the patient has an open airway. Look for and remove avulsed teeth and parts of broken dental appliances. Wrap a avulsed tooth in a dressing. Avulsed tooth is just a knocked out tooth. Just always make sure you got suction ready. If there's a lot of bleeding, there's high potential for airway issues. You respond to a street corner to find a 26-year-old male prone, holding a bloody t-shirt to his head. He reports that he was struck with a machete. What are your concerns? How you proceed? So with the machete, it's not a terribly sharp object, so you may have an open or closed head injury. You're going to proceed by just assessing the injury and providing appropriate care from there. You may also look at this as being a blunt injury, and I would suggest spinal precautions as well. Injuries to the spine. Injuries to the cervical spine can cause paralysis, impaired breathing, or cause death. These are caused by forces to the head, neck, back, chest, pelvis, or legs. Paralysis is damage to the spine that results in a temporary or permanent loss of mobility and feeling. Injuries to the neck. Numbness, loss of feeling, or paralysis involving the arms and the legs. If you have an injury below the neck, the numbness, loss of feeling, or paralysis is going to be in the legs with no problems in the arms. So when you're assessing a patient for a spine injury, you want to see, do the arms or legs feel numb? Can they feel you touch their hands or feet? Can they squeeze your hand? You also want to look and feel gently for injuries and deformities. See if the patient can move the arms and the legs. A lot of times when I'm coming up to somebody with some type of trauma injury, I want to obviously immediately take spinal immobilization. After I do that, I ask them, can you move your arms and your legs? That's just going to let me know a lot of information very quickly. The signs and symptoms of spine injury is going to be pain over the spine, deformity over the spine, numbness, weakness, tingling in the extremities, loss of sensation, paralysis, incontinence, could be bladder or bowel incontinence, a priapism, which is an erect penis.
C-spine immobilization. Most people assume that forces to the head, neck, and back cause cervical spine injuries, yet injuries to the chest, pelvis, and legs may also lead to injuries of the spine. Injuries to the spine include fractured or displaced spinal bones, or swelling that presses on the nerves. If a patient has numbness, loss of feeling, or paralysis in the legs, with no reported problems in the arms, the injury is probably below the neck. If numbness, loss of feeling, or paralysis involves both arms and legs, the injury is probably in the neck. Treat the patient as if spinal injuries have occurred. Remember to make sure the patient's airway is open and assist with ventilations if necessary. Control any serious bleeding. Only attempt to splint fractures or move the patient when necessary to control bleeding. Only move the patient to assist with CPR or to protect yourself and the patient from dangers at the scene. To apply a C-spine immobilization collar, CSIC, draw an imaginary line across the top of the shoulders and bottom of the chin. Use your fingers to measure the distance from shoulder to chin. The distance between the sizing post, black fastener, and lower edge of the plastic should match the number of stacked fingers measured from the patient's neck. After adjusting the size, slide the CSIC up the chest wall. The chin must cover the central fastener in the chin piece. Bring the collar around the neck and secure the collar.
Recheck the position of the patient's head collar for proper alignment. With the collar alone in place, there can still be some movement of the lower cervical region. Maintain the patient's head in a neutral position. Place the board parallel to the patient. Have two rescuers kneel at the patient's side. A third EMT stabilizes the head, while the others reach across the patient to position their hands properly. The EMTB at the head directs the others to roll the patient as a unit. Roll the patient as a unit onto the board. Secure the patient to the board, torso first, then legs above and below the knee. Pad and immobilize the patient's head. Reassess the patient's distal pulse, motor function, and sensation, PMS.
Abnormal posturing is a sign of significant head injury. Abnormal extension, which is dysvertebrate posture. You see everything's kind of going away from the body. This is abnormal posturing, decorticate posturing. You see how our arms and legs are rotated inward towards the spine. If you'll think of decorticate, I know it's spelled differently, but decorticate is towards the cord. That's just a good way to remember this. Alright, check all extremities for circulation, sensation, movement. Palpate the neck anterior and posterior for pain and deformity. Palpate the spine for pain and deformity. Palpate the neck, anterior and posterior, for pain and deformity. Palpate the spine for pain and deformity. If you'll see that she's maintaining spinal immobilization while he's palpating the spine. Check all extremities for circulation, sensation, and movement. CSM is an abbreviation for that. Another one is PMS, which is basically the same thing. It's pulse, motor, and sensation. Assess motor function of both feet simultaneously. Assess sensation of both feet by checking for numbness and tingling. Assess motor function of both feet simultaneously. This is just demonstrating that. This is demonstrating assessing sensation of both feet. Check all extremities for circulation, sensation, or movement. CSM. Assess motor function of both hands simultaneously. Assess sensation of both hands by checking for numbness and tingling. This is just demonstrating them assessing the motor function of the hands. He's got the individual gripping his fingers. Alright, they're assessing the sensation by squeezing the fingertips. Alright, this is just a summary of observations. If you've got somebody that has, no real signs or symptoms, there's probably no serious spinal cord injury. If they can't feel, can't move, or can't raise their legs, you may have a injury to the lower spinal cord. If they've got diaphragmatic breathing, which is seen as belly breathing, they can feel, move, and squeeze with their upper extremities, but their lower extremities they can't feel, they can't move, and they can't raise. There's a probable injury to the spinal cord somewhere below the neck. And if you've got issues with breathing, they can't feel, can't move, and can't squeeze with their upper extremities, and they can't feel, can't move, and can't raise their lower extremities, they've probably got a spinal injury in the neck. Spinal cord injury, to be specific. Caring for a suspected spine injury, you're going to perform your primary assessment. Ensure ABCs are intact. Manually stabilize the head so the neck, spine do not move and are kept in line. Attempt jaw thrust maneuver first. If that doesn't work, you can move into the head tilt chin lift maneuver. Only if you can't open the airway with the jaw thrust. Alright, using one hand to provide manual stabilization of the head when you are at the side of the injured patient. Alright, so he's providing manual stabilization with one hand while he's trying to assess her. Alright, this is the same individual with a partner. His partner's providing manual stabilization while he's doing his assessment. Alright, when you're trying to do manual stabilization, you want to approach the person from the side and place your hand on the forehead to minimize the movement. This is when you're by yourself. You can kneel at the top of the patient's head and use both hands to grasp the head from the sides. This is if you've got a partner. We talked about this the first night of class. I would always suggest telling the patient, hey, do not move your head or neck. Just answer yes or no. Do not turn your head to look at me. You don't want them to inadvertently injure their neck further. Alright, make certain that the airway is open. Attempt to control serious bleeding. Always conclude unresponsive trauma patient has spinal injuries. Do not attempt to splint long bone injuries if indications of spine injuries unless you have an appropriate help. So what this is saying is if somebody's unresponsive and they sustain trauma, just always assume that they have sustained some type of spinal injury and go ahead and immobilize them fully on a long spine board. Alright, rules for care of spine injury continued. Never move the patient with suspected spine injuries unless you must provide CPR. Keep the patient laying still. Continuously monitor patients with possible spine injuries. All right, cervical collars. These stabilize the head and the neck by selecting and applying a cervical collar that is size appropriate for the patient. Check to see that the sides of the collar do not ride too far above or below the earlobes. Confirm the chin fits properly in the collar. The collar should be snug on all sides, but not too tight or not too loose. Consider using a different size or adjusting the collar if it does not fit properly. Maintain manual stabilization once the collar is applied or if a collar is not available. Alright, so you got to learn to measure for safe C-collar fit. We'll practice that in class again. This is just an image of a typical rigid C-collar. It's also adjustable. This is a soft cervical collar, also one that we're typically not going to use in the emergency system. Alright, so when it's properly fitted, the size of the rigid collar should come very close or slightly overlap the earlobe. This is incorrect placement. It's not adjusted appropriately. Alright, when it's properly fitted, the patient's chin will fit completely and snugly within the saddle of the rigid collar. In this one, the chin is not fitted appropriately. Establish manual stabilization of the head while your partner selects a collar. This is for someone in a vehicle. So you're holding the head and your partner's adjusting it. This is them applying the collar. Alright, you're going to secure the collar in place by overlapping the Velcro. We did all this in class, guys, so we're going to skim through these fairly quickly. Alright, helmet removal. So you're going to remove it immediately if you have issues with the airway, breathing, or circulation. For an unresponsive patient wearing a helmet, always suspect a spine injury. You're going to monitor airway, breathing, and circulation. So there are helmet stickers on the market that read, "Do not remove the helmet." The EMR should honor the patient's request and place padding where needed to ensure the cervical stabilization. That's true unless there's issues with airway, breathing, and circulation. Airway, breathing, circulation issue, always remove helmet. Alright, properly immobilize the spine. For football players wearing shoulder pads, helmet left in place keeps the cervical spine in the midline position. You can just remove the face mask from the football helmet, generally with just a couple screws, or you can cut off the retaining straps with your scissors most of the time. Alright, if the helmet has a face guard or shield, remove it to gain access to the airway. We just talked about that. Provide care to any unresponsive patient as if there is a spine injury. When you find helmeted patient face down or on the side, log roll him onto his back. Well-fitting helmet can stay in place as long as the patient is breathing. Remove it if it does not fit snugly. Remove if cardiac or respiratory arrest occurs. Alright, while holding manual stabilization, expose the neck and remove the straps that secure the helmet in place. The rescuer at the top grasps the straps and begins to pull the helmet off while the rescuer stabilizes the head. Once the helmet is removed, gently lower the patient's head to the ground. Maintain manual stabilization of the head while the collar is placed on the patient. Alright, think about it. You respond to an MVC where a single vehicle impacted a utility pole, snapping it into two pieces. You find the driver, who is an elderly female lying in the back seat with her legs between the two front seats. She is unresponsive but confused. What are your concerns? Our concerns are this is a high mechanism accident. She is also unresponsive. We're going to proceed by immediately assuming she has a spinal injury. We're going to assess our ABCs and take manual stable spinal immobilization procedures. We're going to continue with care, evaluating for signs of shock. Alright, summary. Open head injuries result in a break in the bone and the overlying soft tissue. Closed head injuries involve no opening of the skull. May be soft tissue damage of the scalp. Head injuries can range from mild concussion to a significant open fracture of the skull. Signs and symptoms of head injuries could be a mild headache, bleeding of the scalp, all the way up to an altered mental status, deformity of the cranium, unresponsiveness. You may have convulsions, vomiting, aggressive behavior. They may ask repetitive questions. Alright, so manage and monitor the airway, breathing, circulation. Consider possibility of neck injury and provide care accordingly. Control bleeding. Airway is always the top priority. Unresponsive injured person with suspected neck injury. Begin with the jaw thrust maneuver. If the jaw thrust maneuver does not work, use the head tilt chin lift. For spinal injury, you definitely want to identify the mechanism of injury. Assume there's a spine injury if the mechanism suggests it, even if the uninjured person has no obvious signs or symptoms. Pain or deformity over the injury site may indicate a spine injury. Also, numbness, tingling, weakness of the extremities, loss of sensation, paralysis, incontinence. Once ABCs are intact, primary concern becomes stabilization of the head, neck, and spine. Provide manual stabilization of the head and neck until EMS arrives. Place patient onto a long spine board. Let's go over some review questions. All right, what are the major components of the spinal column? You're going to have the cervical, the thoracic, the lumbar region. What are the major components of the nervous system? You got the peripheral nervous system and the central nervous system. What are the major components of the cranium? Refer to your book for all the major bones. What is the relationship of mechanism of injury to the potential for spine injury? If the mechanism suggests that there is a potential for spine injury, always treat the patient as such. All right, what are the signs and symptoms of a head injury? They can be pretty broad. You can have anything related to a mild headache, bleeding of the scalp. You can have an altered mental status. You can have deformity of the cranium, or they could be completely unresponsive. What's the difference between an open and closed head injury? Open head injury is going to involve opening of the cranium, exposing the brain or other soft tissues up under the skull. Closed injury is going to be with the cranium intact. All right, how would you provide the appropriate assessment and care for a patient with a head injury? It's just going to depend on how your patient presents. There's too much really to go over in this question to cover all the bases, but you just have to treat the patient depending on how they present. One big thing is if they're unresponsive, you always want to treat them as they also have a spinal injury. All right, what are the signs and symptoms of a spine injury? You can have, for more high spinal injuries in the neck area, you could have issues with breathing, It would cause the diaphragm to be paralyzed. You could have loss of pulse, motor, and sensation in all extremities. If it was below the neck, you may just see um, loss of pulse, motor, and sensation to the lower extremities while breathing and upper extremities remain intact. All right, how would you provide appropriate assessment and care for a patient with a suspected spine injury? Airway, breathing, circulation always take precedence over protecting the spine. Still very important. So you assess them accordingly. If you have a significant mechanism of injury, always assume they have a spinal injury and just proceed with whatever care is required for the specific situation. What are special considerations of airway management for a patient with a suspected cervical spine injury? You have to be able to maintain the airway. If it's possible, you want to open the airway with a jaw thrust maneuver. However, if that is ineffective, you're going to have to move to a head tilt chin lift maneuver. Airway is always going to take priority, so just treat your patient accordingly.